Welcome to this Experts Online session on the auditory brainstem implants in children and other indications. I think it's 3 o'clock. We can start with our presentation. I will start with some housekeeping rules that you're probably all familiar with by now. So please name yourself with your name, maybe organization, by clicking on your name in the participants panel. To avoid background noise during this meeting, please mute your microphone or do not speak, but we prefer if you mute your microphone. To have a stable internet connection, please close all other software on your computer or your device that you're using for attending this meeting. Your questions and comments are always welcome. Please put those into the chat. You can find this at the bottom of Zoom. And we will get to that at the end of the session. We do have English captioning available for you. You also find this in the Zoom menu at the bottom of your screen. So if you click that, you will have a transcript of today's session. To start off with, I prepared a little question for you on mentimeter.com. So in order to access this, please go to menti.com and enter the 7-digit code you see on the left side of the screen, or use your smartphone, open up your camera or QR code reader, and take a picture of the QR code, and it will lead you to menti.com and the question. The question is, which condition would you consider to be appropriately treated with an auditory brainstem implant? Or in other words, which indication comes to your mind when you hear ABI? You have 3 options to enter something and submit that to us. So the malformations coming in, absence of the auditory nerve, that's absolutely correct. I see NF2 here, that's the classical that even grows, so that's what a lot of people know. Yeah, auditory nerve lesions, not excitable auditory nerve. Yes, that's all very correct here. So I think that's a beautiful overview of what the auditory brainstem implant is being used for. Thank you. This is your first task for the day. It will come back slightly later as well. We at MED-EL have a long-standing history with an ABI system. The development started back in 1995 as a cooperation between the universities of Innsbruck and Würzburg, with the very first ABI manufactured by MED-EL being implanted in Würzburg by our today's speaker, together with Professor Müller in Würzburg in 1997. Since then, the device received the CE mark for the indication of neurofibromatosis type 2 in 2003, and then saw several hardware updates throughout the years. And we are very proud that in 2017, the initial indication could be extended to further patients, and it's now in fact auditory nerve hypoplasia and aplasia, cochlear nerve disruption, severe cochlear ossification, and it can be implanted down to children aged 12 months and older. This was a great achievement that was only possible with the help of you clinicians out there, collecting data, seeing the patients, treating the patients the best way you can. I have to make a small note here. Not all products or indications that we are presenting here today are available or approved in your market. Please get in contact with your local sales team, and they will be able to help you on the possibilities you have in your area. Sorry, this is not getting forward. Yeah, now. So the MED-EL ABI system works by bypassing all structures of the inner ear and the auditory nerve, and it directly stimulates the cochlear nucleus of the brainstem. So far, I think we are all on the same level. The MED-EL system consists of an implant. The latest version of it is now with the MI1200 Synchrony, either pin or no pin version, and it can be used with the current MED-EL audio processors like the Sonnet 2 or the Rondo 3. We have some dedicated surgical tools or measurement systems available that you can use at your discretion during the surgery to get the proper indication for an ABI, and also then to find the proper placing of the ABI system on the brainstem. Today with us, we have Professor Behr. He is a neurosurgeon and director of the Neurosurgery Clinic in Fulda, and also the director of the Head and Neurosurgery Clinic. He finished his medical exams in 1983, then specialized in neurosurgery in Gießen, and later became a senior consultant at the University Clinic of Würzburg. That was when he took part in that clinical trial where the first ABI was implanted. He later received a call as a C3 professor for skull-based surgery in Köln in 1999. And then since 2001, he is the director of the Neurosurgery Clinic in Fulda. He's definitely one of the most experienced surgeons worldwide when it comes to auditory brainstem implants. And as I said, he implanted the very first MED-EL ABI. He was the president of the European Skull-Based Society and lives in a very interdisciplinary approach in his work in benefiting patients. If he is not too busy with his surgeries around the world, Professor Behr engages in social and ecological projects in and around Fulda. And currently, he has a particular focus on the black grouse in the UNESCO World Heritage Park or Biosphere Reserve, Rhön, which is nearby Fulda. So with that, I want to hand over to Professor Behr and his presentation on auditory brainstem implants in children and other indications. Professor Behr.
Yes, hello.
To you now.
Yes, I start my presentation now. And I thank you very much, Florian, for your introduction and the nice words you have for me. And I want to say hello, good morning, good afternoon, and good evening all around the world where you're sitting and listening to this presentation. As it was shown in the Mentimeter, your ideas around ABI are more or less focusing on NF2 and on malformations, and that is exactly what we want to address during this next 60 minutes. And I hope maybe you have lots of questions after the presentation or in between. Okay, let's go a little bit back. At the beginning of cochlear implantations in 1970, there were some ideas. For example, cochlear implants could never ever restore hearing, but only single sounds. Speech understanding would not be possible. Open speech understanding will never be reached. And maybe the implantees will hear some environmental sounds. So expectations were quite low. Reality now, however, is deaf children hear almost normal or go to a normal school. Deaf adults are integrated in normal day and normal life and work, and cochlear implants patients live an almost normal life. So what's about ABI? The first ABI was implanted by this man. This is Professor Hitzelberger in Los Angeles. He's a neurosurgeon. And this is his very first patient, NF2 patient. And she had this very simple implant for about 20 years and was, as it was published, also very happy with this implant. So people at that time believed that ABI could not be better than a single channel cochlear implant, so very rudimentary cochlear implant. Speech understanding would never ever be possible. Open set speech understanding also not possible. And ABI will only support lip reading and maybe will improve the hearing by hearing of environmental sounds. So expectations were low. But one of our first patients, you see her picture here, Sylvia from Warsaw. I operated her in Warsaw in 1998, and she's an excellent performer with an ABI NF2 patient, and she uses telephone. So what can you learn about this? I will tell it to you. Never ever believe the experts. So you are free now to leave the session if you like, but you also may continue, and maybe I can give you some new ideas. What are the indications for an ABI, and what is about candidacy? Okay, I think you know this very well, but I just want to address it a little bit. Of course, deafness induced by a tumor, schwannoma, mainly in NF2 patients. Some cases also have meningiomas, but very rarely. There are deafness by infections, for example, meningitis with an additional ossification of the cochlea or encephalitis, and then a cochlear implant is no more possible because of the ossification. Deafness by drugs, by trauma, by inborn diseases, and that's now what you addressed in the Mentimeter question, aplasia of the cochlea or aplasia of the cochlear nerve, hypoplasia. Syndromal lesions, for example, Schwarze syndrome. And in some rare indications, there's a study at the moment going on untreatable tinnitus. So these are the main indications. And of course, focus is NF2 and focus is aplasia of the cochlea of the cochlear nerve. The implant itself I used, it was already introduced by Mr. Schwarze. Is certified for and has a CE mark for children 1 year or older without tumors, so malformation children, and tumor cases from 15 years onwards. It is also certified for MRI with 1.5 Tesla strength with or without magnet. This is the system itself. This is the processor, the speech processor. This is the coil, which is attached to the skin, and with a magnet it keeps to the implant itself. This is the transceiver, which is implanted into a bony well at the skull, and by a cable, you can see it here, the information is transmitted to this probe, which is located at the cochlear nucleus and the brainstem. And this is the test electrode with 4 contacts for the positioning, finding the right position of the stimulating probe. I will come back to this later on. Many people ask me, can you define criteria which will give a positive outcome, or probably positive outcome? And I say, yes, in some cases it is, but it is no guarantee, of course. They are, I call them preoperative criteria, and there are some intraoperative criteria for a good outcome. Preoperative, if the patient has little additional handicap. This is very important for the children who have, for example, syndromal lesions. A short period of deafness seems to be important. Free brainstem, I call free brainstem an issue where there are no other lesions around the brainstem, especially in tumor patients, so in NF2. The implantee should be intelligent, motivated, and very important is caregiver support. Interruptive criteria, of course, the tumor resection should be uneventful, not so much bleedings. Clear landmarks are important to place the electrode at the right position, at the right place for stimulating the cochlear nucleus. The lateral recess of the 4th ventricle, where the location of the cochlear nucleus is, should be free and good, and should be opened very, very good. And we should have intraoperative recordable electric bearers. I will come to this also later on. What are the operative techniques or the operative concept? First of all, of course, tumor resection in the NF2 patients. If this is uneventful in the same operation, we do the implantation of the ABI So in general, no second intervention or operation is necessary, no additional hospital stay. And if everything went well, the first fitting of the ABI will happen 6 weeks, normally 6 to 8 weeks after the surgery. So this is the course. And now the question is also very often, how shall I position the patient? So we here in Fulda, we use the Semisitting Position, which is, you see a schematic drawing here, which enables us to have a very free field in the posterior fossa. We can see the nerves very well and do a very precise dissection of the tumor and brainstem. You see here some cables for the intraoperative monitoring of the facial nerve, but also the prone position, lying position is also possible, especially in cases where we found an open foramen ovale, which we always test before surgery by ultrasound echography. So mainly, however, we use the semi-sitting position, and this is the positioning of the patient we use only sometimes. And then the head of the patient should be rotated to the side of the tumor and a little bit inclinated, and then we can do the approach behind the ear, so-called retrosigmoid, suboccipital trepanation. You see it here as a schematic drawing with 4 boreholes or 2 boreholes. Normally 2 boreholes are sufficient to open the skull and come into the posterior fossa. And then we reach the tumor. You see here how it looks like in the operating room, the surgeon and the patient, a semi-sitting position, nurses, and so on. So what are the advantages of a semi-sitting position in these procedures? And I just want to stress, it's only the tumor procedures, not the procedures where we do the implantation in children. In that case, the patient is always lying. Advantages are, first of all, you do not need so much suction of blood and irrigation fluid because it comes down by gravity. There is easy control of bleedings. You can use a bimanual preparation of the arachnoid membrane, and the arachnoid membrane is, so to say, the girlfriend of the neurosurgeon because it covers all the important structures, and if you keep in this plane, you are happy and you can preserve the nerves. There is an excellent anatomical exposure of the tumor, of the brainstem, of the cranial nerves, and there is less blood at the target of interest, so to say, at the dissection plane between brainstem and between the tumor surface. We can do reliable monitoring of cranial nerves and also a safe glue application in a more or less dry environment. So the Contra argument against semi-sitting position is the risk of venous air embolism. And one of my co-workers, Dr. Wakentin, he examined a nice number of patients, almost 300, and he found out that of all surgeries where there was no open foramen ovale, we only had 0.4% morbidity, no mortality, and 100% no lasting morbidity. So it's a very safe procedure if you are a little bit acquainted to, and you need a very well, or you need an anesthesiologist who is trained in this procedure. Of course, that's important. So I come to the next step, the use of the test electrode. The test electrode, you see here, has 4 contacts. You see the test electrode here. It has the same size as the stimulating electrode, and it has no mesh on its back. And this makes this, this probe very easily be manipulated and navigated in the lateral recess. And with this, by this means you can find, first of all, you can find if there is a stimulation possible at all. If not, you don't have to open the package of the implant. And if you have a stimulation result, you can find then the best place for the implantation of the stimulating probe with the 12 contacts. So you find the best implantation site by stimulation of all electrode pairs, and then you can say, okay, this is the place I have to put the stimulating electrode. This is what you see during the operation. This is one example from electrode 9 of the probe, and you see here with the lower current stimulation and with the higher current of stimulation, you see a much better recording of the E-bearer. And when you have such a recording, you know this is a very good place to put in the stimulating electrode. So where do you want to go to? You see here in green, this is a schematic picture of the hearing pathway. This is the cochlear nucleus. And in gray, you see the ventricular system of the human. And this here is the aqueduct, and here you see the fourth ventricle, and this is the lateral recess of the fourth ventricle, here foramen of Luschke. And what we have to do during surgery, we have to open the foramen of Luschke. This sounds easy, but it is sometimes covered with tissue, with membranes. There are lots of vessels around this opening, and you have to open it wide enough to push in and to implant the electrode for stimulation of the cochlear nucleus, which is here shown in green, number 17. So this is the goal of our procedure, to find the best place of stimulation. And I show you a video. You see here, this is the foramen of Luschke. Should start, yes. This is the foramen of Luschke, but you see no foramen, it's occluded. It's very often occluded. And you see here the lower cranial nerves, glossopharyngeal nerve, vagus. And then you have to open the foramen partially with a sharp dissection with the microscissors, as you can see here. And very, very gently, not to hurt the tissue here. You see a white tissue coming up. This is the floor of the fourth ventricle. And if you hurt this area, then below there are the nerves, of the cochlear nucleus. So you have to open it wide enough to push in the electrode. So next step, it is a little bit difficult to see, but I think you can see it here. It's a little bit translucent. This is the 4-contact test electrode. You put it into the lateral recess and do the stimulation of all the 4 contacts which are possible and find the best place. And then you cut the mesh of the stimulating electrode. This is the permanent electrode, of course, with 12 contacts and 12 stimulation poles. And then you put it into the lateral recess, or better, you lie it on the cochlear nucleus. Sometimes you see that people try to squeeze it in and it doesn't want to fit into the recess. This is not a good way to do the operation. The recess should be very open, and the positioning of the probe should be, as you see it here, without any damage to the very delicate nervous structures you find below the surface here in the cochlear nucleus area. Then it's covered with some Surgicel here, and it's fixed and with fibrin glue and with see it here with fibrin glue. And then I use Tachosil, you see it here. This is instant fibrin glue, which is attached to a tissue, and it fixes the probe additional to this sealant here. So this is the implantation. Here you see some pictures very nicely. You can see here the glossopharyngeal nerve, vagal nerve. This is the opening of the lateral recess, exactly as you have seen it in the video. And here you can see how the stimulating electrode, the 12-contact stimulating electrode, is implanted into the lateral recess on the cochlear nucleus. That's how it should look postoperatively in the CT scan. We always perform 1 day after the operation a CT to see where the location of the probe is, especially for later when you have to do some other CT scans to compare if there is the suspicion of a dislocation of the probe. And this is the intraoperative picture after the surgery with a housing. It's an older version of the ABI with the housing fixed in the bone well, which is drilled out, and then the electrode is going down like this. This is the reference electrode. Okay, now we have a break. If you like, you can jump into the scene, but I would not recommend it. So I give back to Mr. Schwarze for some questions or comments as you like.
Yeah, thank you. I think great to have a quick break at the lake after this really nice introduction into the surgical aspects of the ABI. It makes everything look so easy when you show us here, but for sure it's not an easy thing at all to do. Now we're coming to a tradition in the Experts Online series. We're going to have our group picture. So I would like to ask you all to turn on your camera, grab a mug or something in your hand, or just show us your smile on the camera. And Harry next to me will take the group picture for us, and we can have that as a memory for today's session. Okay, thank you, everyone. So that was task 1 in the break to get you a bit moving again. Now task 2 will be another Mentimeter question that you can access like before. You will see a 7-digit code that Harry puts up for us. And you can, again, go to menti.com, enter that code, or use your smartphone to browse to that website if it does it, like mine doesn't do it right now. Yeah, it works. So the question is, does your institution see children treated with an auditory brainstem implant? So I see a lot of yeses coming in here. I was rather expecting the opposite, but it's very nice that we have a lot of experienced people here in the audience, but also some that do not see children. Thank you for being with us today and showing the interest in this. I hope you will stay with us for the results that Professor Behr is showing us now that he acquired over the last couple of years in the cases he operated on or saw in other clinics. So I'm handing that back over to Professor Behr. Can you please share your presentation again and continue with the results of the ABI or with the ABI?
Let's see.
So I already see some questions coming in. I think we will have an interesting discussion then at the end of the second part of your presentation.
So as you already mentioned, the first implantation I did was in 1997 in Würzburg. It's now a long time ago. And meanwhile, I have 140, a little bit more than 140 implantations and also re-implantations, also some revisions. I saw there was a questions about revisions. I must say I had this chapter in my presentation, but I skipped it due to the time. But of course, it is an interesting question when to do or how to do revisions. Okay, what are the achievements in general of ABI? So it has proven for sure its safety and efficacy. It has got a CE mark. It is certificated for NF2 cases and children. I already mentioned this, and it has proven its compatibility to MRI examinations. Clinically, it has shown its effectiveness in NF2 patients. Without any doubts, I will come to the results in a few minutes. Effectiveness also in pre- and post-lingually deaf children. We got the possibility of bilateral implantations and revision surgeries. I will skip both of these topics. And also it's in a study phase, I must say, untreatable tinnitus to treat it with an ABI. So what do the patients say? In a study in 2013, we investigated this, and what we found is that around 1/3 of the patients is very satisfied with this. These are NF2 patients, I must say. 1/3 are very satisfied, around 40% are almost fairly satisfied, and 26%, 1/4, you can say, is adequately satisfied. So it is well appreciated of the patients, and I only know a few patients, really not a handful, who are non-users. So let's go back to the data from the early years. It is data from the US. One of my co-workers, Johannes Kuchter, he was in the States and he examined in Los Angeles the patients operated there. And what you can see here, the mean percentage of correct sentence visual mode, this means lip reading, is 22%. And with the ABI, it increases to 37%. But what you don't see is that there is a number of patients who have only auditory speech or word recognition in this series. So we published in 2007 a series on NF2 patients. And what you see here is how the patients developed hearing over 1 year. And what you can see here after 1 year, after 12 months, the average level of auditory only, but that means only with the ABI, without lip reading, of sentence identification was 50%. And if we add the lip reading, the visual cue, so it increases to almost 80%. So it's a huge difference between the older data and the data in the early 2000s. It came now that some of our patients were very good performers. And I must say there was some rumor in the community that this is probably not true or so. And then Bob Shannon, he is the chief audiologist of the Hay Institute in Los Angeles. He came to Germany and to Poland, and he examined these patients. And what he's found, he published and showed us at the Uppsala conference in 2010. And what he's showed that new NF2 results are much better. This is the new NF2 results. This is CI. This is new NF2 results. And that means that 70% of the patients have more than 80% of correct words and sentences. And he stated that some NF2 ABIs are able to understand speech similar to the best CIs, 100% open set, quiet, conversational use of telephone, speech recognition of 50% in plus 3 decibel sound noise ratio. And the result was that so good speech recognition is possible with NF2 and an ABI. And that showed all the people who were working with the ABI and with NF2 that results can be better as one was thinking in the past. So some NF2 patients had excellent results, and there is a large variability in hearing performance. And the reason are, we did not know the reason, so we wanted to find them out. How do we achieve good results in more NF2 patients as we have seen so far? We launched a study on good performance. That means that we looked into the total numbers of NF2 patients who were implanted with a MED-EL device. This was 84 patients at that time. And we set a threshold of 30%. So good performer was defined if he was able to have 30% sentence recognition only with the ABI, so without any additional visual cue. And what we found was 26. So that means that 31% of this group was able to hear at least 30% of correct sentences or better. And what we found is the factors we found out that they are important to achieve a good result. So that was short duration of deafness. So if an F2 patient due to tumor growth is becoming deaf, so you should not wait too long, 1 year or 2 years, no longer. In our studies it was 1 year. There are other studies who showed it's 2 years, so it is short. Important is that the patient has the ability to hear more different pitches. That means more or equal to 9. There should be a low MCL level, less than 28 nanocoulomb. A high stimulation rate with 1200 or more than 1200 pulses per second and per electrode. And we found in our series that the semisitting position, the hearing of correct sentences without only with the ABI was 65%, and in the lane position it was 45%. So there was an advantage of the semisitting position. And of course, you should have during the operation positive Bjer recordings. So what we found was that patients better than 30% of sentence recognition, they had a minimum number of 5 active electrodes and a minimum number of 5 different pitches. And the stimulation rate was 350 pulses per second, and the maximum stimulation charge 141 nanocoulomb. This is for those patients who had better than 30% of sentences. But we had also patients better than 80% of sentence recognition. And in those patients, we found that there is a minimum number of 8 electrodes, a minimum number of pitches, of course, also of 8. And the stimulation rate is very much higher. It's 1200 pulses per second an electrode. And the stimulation charge is much lower. That means 28 nanocoulomb. When you see 141 nanocoulomb and 28 nanocoulomb. What does it mean? It means that the implantation of the probe is very, very precise to the neurons of the cochlear nucleus, and that allows a low stimulation card and a high stimulation rate and a higher number of different pitches. That is what we learned about from this study. So what are our recommendations? Selection of the patient. There should be a short duration of deafness. They should be motivated, and there should be a caregiver support. This is very important. They should have the help of their friends and families. Of course, MRI spine and plexus and peripheral nerves, we recommend to do this prior to surgery to find out if there are other tumors. The setup, semisitting, I mentioned this already. Intensive monitoring, which is very important, is Bjer during the electrode with the test electrode. Surgery, this is also important, of course. You may not heard this very sensitive neural structures of the brainstem and of the lateral recess. We do intensive monitoring. Sometimes, even in children, the Bjer monitoring lasts longer than the approach to the foramen of Luschke. Very important, and I didn't mention this, but I want to stress this, is the fitting after surgery. The people who do the fitting, the audiologists, they need to have experience, indulgence, and motivation. And revision, of course, it is possible, but we can maybe discuss it later on. For the NF2 patients, it is of course important because they have to face tumor regrowth during time. So now I come to the children. Why ABI in children? We know that in prelingually deaf children, CI is a very good method to restore hearing. So it should also work with the ABI. And what we learned from other studies is that in general, also good results in adults, especially in non-tumor cases, can be achieved with the ABI. And it is in the children who have no chance to get a cochlear implant, it's the only chance to restore hearing by implantation of an ABI. we have to look at some surgical aspects, because I already mentioned it. The approach is a little bit different of the tumor cases. It is always in the prone position, and it's retrosigmoid. We use also a conventional neuromonitoring, but you have to have in mind that in such cases where you have an anomaly, let's say an anomaly of the cochlea where you cannot do a cochlear implantation, or a aplasia of the cochlear nerve, you may also have other anomalies. For example, I also found the location of the choroid plexus was different to a normal situation. There was a dislocation of the facial nerve. You don't see a facial nerve at the place it should be, but it is there because the patient has no facial palsy. The lateral recess is quite often occluded, especially in the younger children, more than 50% in my experience. And the preparation may be very difficult to open the lateral recess. And you may be misled and you think you are in front of the lateral recess, but you are not. And then you open the brainstem somewhere and it's clear what happens here. So you also have quite often vessels around the lateral recess, in our experience 75%. And especially in the younger kids, the lateral recess may be quite deep and very medial, and it's difficult to find your way to this location. So that is prone position. You see here the incision. You also can make a straight incision, but I like this this flap to cover the implant nicely. And I did up to now, since 2009, 43 ABI implantation in the children, mostly prelingual, 2 postlingual, and we just examined our group and included 38 of these 43 patients who had at least 1 year of ABI hearing and who were prelingual deaf. Mean age was a little bit more than 3 years. These are the pathologies we found, mostly cochlear nerve aplasia, also hypoplasia, but also, as you can see here, other syndromic diseases which do not have the same results. I will show it soon. This is the CAP score. Most of you know this and you're familiar with this. We used it for evaluation of our cases. So 0 means no awareness of environmental sounds. 7 is best uses the telephone. And with I want to stress number 4, because there speech sounds, the discrimination of speech sounds starts. And in CAP 5 means that phrases can be understood without lip reading. So this is the beginning of, at 5, it is the beginning of open set speech understanding. That means hearing with the ABI without other additional visual cues, for example. So this is a graph of our patients in blue. I must apologize, this is in German, but I will explain you in English. In blue, these are all the children who have no additional handicap. And you see over the time, the CAP scores increase, and they reach 6, and some of them, they reach 7. And these in yellow, these are the children who have additional syndromic lesions, who are mentally retarded, for example, and you can see that they don't reach much more than 3, CAP 3, so they don't achieve open set speech understanding. And this is not only in our series, this is also shown in other series. What is important is evaluation of age. When we show how the results are in kids who are implanted over the age of 36 months and younger than 36 months, you can see that the younger ones are doing better than the older ones. This is a statistically significant difference, but of course, also the patients who are not such well and good performers, they have a benefit from it. So it's not to say, these kids are not to be implanted. No, 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 that I don't want to say. I only want to say you should do the indication early. And this is a regression analysis, and what you can see here, this is the age at implantation in months, and this is the CAP score. And what you can see, you reach highest CAP scores when you have a lower or when the patients are younger at the time of implantation. This is also significant. So in our series, in the children who had no additional handicap but the deafness from birth, 72% were equal or better CAP5. That means, in other words, that 72%, almost 3/4, are able to achieve open set speech understanding. And the handicapped children, they achieved the maximum only of CAP3. And the two postlingual patients, they achieved both CAP7. Postlingually means they had some speech already before they went deaf, mostly by meningitis and then ossification of the cochlea. So this is, I want to show you some examples. This is Louis. Louis came from New Zealand to us, and what you see here, yeah. He's playing with his tablet, and you see when there was some sound, environmental sound, this knocking, he heard something and he turned his head around. So this is CAP1. This is Xenia. I operated her in St. Petersburg in Russia, and I want to thank all the co-workers who invited me to help them establishing their own ABI program, and where I was in the lucky position to share my experiences with them. And this is Xenia from St. Petersburg. Wait a minute. So. You hear, she's not seeing the lip.
Рядом. Мишка. Мышка. Машина.
So he's doing no faults.
Давка. Удавка.
No mistakes. He's hearing perfectly.
Дорожка. Кошка. Кружка. Чашка. Ложка. Призвук слышишь? Угу. Водичка. Жарко. Жертва. Шоколадка. Жажда. Отара. Атака. Шеф. Шарф. Шапка. Шахта. Шахтер. Шахматы. Бомба. Вова. Буханка. Мука. Муха. Рука. Корова. Пурга.
I think it's enough, and what you can see, this little girl, she is deaf from birth, and she learned hearing and speaking, of course, only by this electronic device. And as it was mentioned in the beginning of this presentation, that the whole hearing system is bypassed. So the technical generated signals are brought directly into the brain at the cochlear nucleus. I have another video of her. A few years later, you can see her again, and she's presenting a poem. It's in Russian. I am not speaking Russian, but I think it's a poem.
Я умею обуваться, если только захочу. Я и маленького братца обуваться научу. Вот они, сапожки, этот с левой ножки, этот с правой ножки. Если дождичек пойдет, наденем сапожки. Этот с правой ножки, этот с левой ножки. Вот как хорошо.
That's very nice, I think. Okay, and this is another boy from India whom I operated with my dear friend and colleague from the Behr Institute. If he has listening to us. Greetings to Mohan. And you can see.
Johnny, chुप.
Johnny, papa, it's papa, no papa, then night, no papa, open no mouth,
So he's able to sing a song and to keep the rhythm, and I think this is very impressive. If this is possible, let's say only by a technical device. Okay, in summary, I think that the ABI implantation in children is a safe procedure. Of course, you need some experience to do this. And I think that in doubtful cochlear implant cases where due to a severe cochlear malformation, cochlear implant is doubtful to be successful or is not possible, then you should go for an ABI implantation. Also, of course, if there is a failed cochlear implantation in a previous surgery. I think if we are aware that with the ABI and with a safe procedure, the ABI implantation is, you should try to get a quite early implantation, not to miss the time of the development of the auditory system and the brain, and to get as much as information into the child's brain and hearing system. So early indication for an ABI implantation is recommended. Yes, thank you very much for your attention, and I'm happy that you attended us, and I'm ready to ask your questions if I can. Thank you.
Thank you, Professor Behr, for this really interesting presentation. And I think the smile on the faces of these children is just priceless when they can do their thing in front of the camera. And that this is possible with a technical solution. You were absolutely right with your title of the presentation, or with the first statement on the presentation. It's a brilliant invention that was developed here. I'm seeing some questions coming in. I have one from my side, and I think that's then also going on in some of the questions that I have seen. So I'm asking you to put in further questions into the chat window, please, or raise your hand using the button at the bottom of your screen. Then when asked to, please unmute your microphone and ask Professor Bjer your question. So the first one from me, when you're counseling parents of a deaf child, or I've seen an SSD child, we're coming to that more later, what in your opinion is the most important aspect, or what are the most important aspects, if several?
Yes, thank you for your question. Of course, this is one of the most important questions, because the parents, you must imagine, they have to make a decision to do brain surgery, and this is always a difficult decision to do for your kid. So what I tell them first is that in general the surgery is a very safe procedure, and the next step is, yeah, what will my child hear afterwards, and will my child achieve some speech? And then I must say that on the databases we have with our study, I just showed you the results, and also the other studies from other colleagues, from Coletti and from Sinaroglu in Turkey and so on, they all show that the non-handicapped children, they have really very good chances to develop open speech understanding, and also free speech. And then you have to tell the parents, of course, your child has a good chance, let's say more than 50%, I would say. But in the individual situation, you cannot predict it precisely. So you have, it's a little bit hazardous, let's say. You don't know exactly how your child will react, how the auditory signals which are processed to the brainstem are then processed to the rest of your brain, and what the children can make out of these electronic signals. This is what we don't know. We can have excellent recordings during surgery of the Bjer, as I mentioned, but it may be that there is no result. This is especially in the additionally handicapped patients, I must say. I remember very well a child from New Zealand. We did the implantation here in Fulda, and she has some sort of autism, and she had excellent intraoperative recordings, but she couldn't make anything out of it. So this is something we have to tell the patients, but I would say in the non-handicapped group, there are little contraindications not to do the surgery. In the handicapped group, okay, we have to think there are really very sick children, let's say with a Schwarze syndrome, where you have other problems with the heart and so on, where you have to think about to do the surgery. But also they may have some additional help by this implant. I hope I can. Yeah, I hope I could answer your question a little bit.
Maybe this brings us right to the next question that I see here. Did you ever have to interrupt or postpone a surgery due to an actual complication, especially when you operate in children?
No, no, that was not the case. The surgery, when it was started, could always be finished with the implantation of the probe. We're lucky in that situation. But of course, it may happen. You can imagine situations where you get some bleedings when you do the retraction of the cerebellum to, let's say, too roughly or not gently enough, and then you tear some vessels in the depth, and then you get bleeding there. This may be difficult then. Yeah.
So, but that it stays the way you have it right now. Then I have the next question from Dirk. Why did you use the test electrodes just for testing the Bjer, and why are you not performing the Bjer with the ABI, so the actual electrode, I'm assuming?
Yeah, that's a good question. The reason for the test electrode is quite easy to understand. This test electrode has no mesh on its back, and you can maneuver it in the lateral recess without damaging the surface of the lateral recess. That means the neurons which are just below. And I found, or I must say, there are some anatomic situations where the lateral recess is rather wide, and where you have many possible places to put your stimulating electrode to. And therefore, it's important to maneuver this test electrode to the best place. And we have to do stimulation of all pairs. So that means we have the most medial pair, the most lateral pair, the most upper and lower pair of these four electrodes. We do a bipolar stimulation. And then we can shift the electrode by a few, not even a millimeter, and we get another response during the electrode, during the stimulation. And then we find this best place. And you have, due to the tissue, to the plexus, which is on top of the lateral recess, you have your stimulant electrode with a mesh on it. It sticks very easily to this plexus, and you cannot maneuver it so easily as the test electrode. So this is the reason. But when you have inserted your stimulating electrode, then you have to do another measurement, that you are sure that this is the right place also with your test electrode, because you have to put out test electrode and put in and implant the stimulating electrode, and there can be some changes, let's say, but with some experience, you know, that's not a problem.
Okay, great. For the sake of time, because we are already over time here, I'm trying to summarize the next three questions into one. It's how often do you see the electrode pedal moving? Do you recommend repositioning surgery for if you see such a move? And what would you do if you see poor EABRs during the test electrode and after multiple repositionings? Would you abort the surgery then if you don't see a proper response, or would you put in the correct electrode or the ABI electrode?
I start with the last question. If you are at the right place, you always find one. You always find a recording of the e-bearers. So we had no case where we did not find a proper recording. So implantation in children was always possible, and we always got e-bearer recordings. But I remember an F2 patient 1, where we had no e-bearer recording, and I did not do the implantation in this case. But this was an NF2 case with rather big tumor and also some additional pathology around the brainstem. So this was a severe case, I must say. The next question, what's about revision? Yes, we did some revisions. I mentioned it in the beginning of this presentation. If there is a dislocation of the probe, and you can prove it by CT scans and by the electrophysiology, you have to do another e-bearer recording in anesthesia of the child. And then you can compare the results during surgery and post-surgery. And then you can make your decision to do the revision surgery or not. Important is that the patient had some good hearing before. If not, then maybe if you are sure that you found the right place in the first surgery and you don't get good responses after this, and you only have a doubtful indication that there may be a dislocation, I think I would not do this reimplantation. I did one reimplantation and revision in a handicapped child. This was not successful. But what we did is we did revision of the whole system, because children, they are playing, they are falling sometimes, and they are also falling on their head. And this happened in 2 patients, and so we were able to remove the whole system and implanted a completely new system, which with success. So they reached the same CAP score as they had before. So this is possible. And of course, in the NF2 patients, you also have to be aware of tumor growth, and you will see tumor growth in these patients. And then sometimes the tumor makes a dislocation of the probe, and then you have to do the tumor surgery and do the reimplantation of the probe. So this is was a third part of the question. I don't remember. Or did I answer all the aspects?
I think that answered those questions. I think in the sake of time, we are taking one more question, and then I will let Harry forward you the rest of the questions, and maybe you can get them back to us in writing. A quick one for the end. Would you recommend ABI in SSD children?
Yes, yeah. Single-sided deafness, okay. There is, as far as I know in the world, is no experience, at least no published experience. We just did a PubMed overview of the last 10 years, and we didn't find a paper addressing this topic. But of course, I can imagine that in some cases, it makes a difference if you have a second auditory input, let's say for stereo hearing, location by sound. If it is, or if it will improve the hearing itself, or the possibility of the child to or of the person to communicate, that's, to me, it's not clear. Maybe not, but we have the situation in normal acoustic neuroma patients who often are deaf on the tumor side and they hear quite well on the other side. Mostly they say in a community when they want to speak with several other people, they have problems to understand what they are saying. And they have problems to follow conversation. Maybe in such a situation, this may help to be, let's say, more online in this in this conversation with other people.
So we actually have a patient population that we could learn of.
Yeah. But I think this is also very depending also on the auditory skills of the individual person. Some are good listeners and some are not so good listeners. Maybe we have to learn for the future. I would not say it's a no-go. I think it is an interesting question, and I'm sure that there are patients who will benefit from an implant in a single-side deaf situation. I cannot say more, I think.
Yeah, but so in the sake of time, we are already running way over. Thank you for your time. Thank you for sharing this insight. And thank you to everybody who stuck with us for so long today here. Now, the remaining thing for me is to invite you to our next session in 2 weeks' time. This is on the topic of the road to binaural hearing, optimizing fitting in cochlear implant recipients with single-sided deafness. So there we are again. Next, in 2 weeks' time, this will be with Greet Mertens and Daisy Tavora Vieira. This is on the 19th of May, again from 3 to 4 CET. So same time, same station. Hope I see you there again. Thank you for your participation.
Thank you to all you who are listening to us, and I hope I could encourage you to believe in the ABI. Thank you very much.
Thank you, Professor Behr, and goodbye to everyone.
Goodbye.